Hey there, everybody. It's Adam again, and again, sorry for the technical difficulties we were running into with the test and whatnot. But here is the makeup video where we cover pediatric and geriatric pharmacology. First off, we'll start talking about the geriatric patients. Now, we know this is going to be a huge number of people that you guys are going to be treating in your career, especially if you don't specialize in something like pediatrics. But we certainly know that the geriatric population is getting bigger every year. In 2015, they estimated around 15% of the U.S. population was actually greater than 65 years of age, which is our cutoff for considering someone a geriatric patient. And their life expectancy is, around 79 years or so. So there's a good, kind of 14 years on average you'll be treating these patients for a lot of their chronic disease states. And also, we're going to see there's several different pharmacodynamic changes that occur as they get older. Now, there's lots of different types of assessments that you should do when evaluating a geriatric patient about their medications. Here's an example of the comprehensive geriatric assessment. Again, it's not the only one that's out there, but just an example to show you some of the things that we would be looking for. And essentially what we're going to be doing is looking at some of these elderly patients with complex medical problems, and we'll emphasize certain functional status issues and also quality of life issues. So looking at just how functional they are able to get around in their day-to-day life, look at the medical issues they may be having, psychosocial capabilities, and also a lot of the limitations around them. And then we'll see that very frequently that this is going to take advantage of an interdisciplinary approach, meaning basically that we're going to see that doctors, nurses, nutritionists, pharmacists, and everyone else in between can get involved and can be very useful for helping to fully assessing these patients and deciding kind of what's the best treatment course for them. So we'll consider activities of daily living. You have kind of the basic ones, which are things like dressing yourselves, going to the bathroom, bathing, all of that. Intermediate activities would be for things like getting out of the house or being able to perform housework around the home, using things like the telephone or going for groceries, all of that. And then you have kind of the more advanced activities, so things like they go out and volunteering or being able to function in their family roles appropriately, and all sorts of things. And so you'll see that as they get more and more complex medical issues, you may see that these start to take a hit, especially with some of the CNS kind of degeneration that occurs with things like dementia and Alzheimer's. That even basic things like bathing and dressing can be very, very difficult, and getting them to a point where they can do these things again can be a huge impact on their quality of life and helping them to become more functional. So looking at nutrition, this can be very important, especially in regards to things like looking at pharmacology and some of the medications they may be on. You'll see that there's a number of reasons for these patients to have inadequate nutrition. It could be issues with, say, limited dentition, or they have ill-fitting dentures. They may have decreased appetite. Some of it could be related back to the medications that they're taking that could suppress appetite. Could be due to untreated depression, loneliness associated with, say, loss of loved ones or different things like that. Certainly, there's a host of medical conditions like constipation, congestive heart failure, cancer, dementia. All that can lead them to not really getting the kind of nutrition that they need, and certainly things like lack of financial resources. So, if it's not for programs like Meals on Wheels, some elderly patients might not actually be able to get food in a lot of cases. So, and not only that, but them actually being able to get to the food and actually able to prepare can be another hindrance to them getting adequate nutrition. So oftentimes when you're assessing these patients, it's important to ask about how much food they've had in the past 24 hours and kind of on average, looking at fluid intake. Dehydration is a big issue with a lot of these patients. It can lead them to have altered pharmacokinetics. We saw already how this can affect volume distribution. Vitamin intake, dietary supplements, which can, of course, have effects on drugs in regards to interactions that can occur there. And so basically, when you're making this checklist, you're assessing for any illnesses or condition that can affect the kind or the amount of food that they consume, trying to figure out, are they eating, enough meals throughout the day? And then if they're getting enough things like fiber, calcium, vitamin D, so like vegetables, fruits, milk, all of that is very important to making sure they're actually getting adequate intake. So other things you can assess for would be alcohol intake, any teeth or mouth problems, financial resources to buy food, whether or not they have any kind of like social support, so if they're eating alone or not. And then again, looking at trends over time, so we're going to be looking at things like, have they been losing weight over the past 6 months, or are they possibly gaining too much weight? And then looking at things like, can they physically, shop, cook, and feed for themselves? We can also do things to assess patients from a laboratory standpoint, and this is really, really important, and I stress this for a lot of patients because many times patients will get put onto a medication or some sort of treatment regimen, and no one ever goes back and kind of checks their labs again over time to see, like, hey, should we be adjusting this at all? Renal function is going to be a huge, huge one that we run into problems with very frequently. So some lab tests you may want to run on your elderly patients include things like their complete metabolic panel. This is good because it covers a wide range of things, including their basic metabolic panel, so looking at their electrolytes, looking at their glucose. Protein stores can be really important because you can actually track kind of chronic malnutrition issues by looking at serum proteins like albumin, looking for acid-base disturbances, kidney function, liver function. All of this can be very, very useful for determining if there's kind of any problems that are coming up, or if we need to adjust certain aspects of their treatment, whether it be medication dosing or how frequently they're giving meds or something like that. Other things we can look at, including their serum cholesterol, their lipid panel, because we know this certainly has an impact on cardiovascular risk over time. We can look at their hemoglobin A1C, which is a monitor for their kind of baseline glucose over the past 3 months or so. Kind of looks at the amount of glycosylated hemoglobin found within the red blood cell. So roughly 3 months worth, kind of telling what their average blood glucose is. So this can be an important marker for checking things like, their diabetes status, if they are being, they're taking their medications appropriately, and they're having good effects on managing their blood sugar. We can also look at their CBC. This helps us to look for things like anemia, by looking at their hemoglobin, hematocrit. We can look for sources of infection by looking at their white blood cell count if that's being affected. And then other things like vitamin B12 levels, the urinalysis. All these can be useful in helping to kind of determine what's going on with the patient, and is there any kind of changes or interventions we should make here. So the big thing with geriatric patients when it comes to meds is that polypharmacy is more often the rule than the exception. And so we consider this use of 5 or more regular medications. And there's many, many different reasons for this. One, as people are living longer, they're typically going to develop more disease states, which is going to require therapy. They have an increase in the number of chronic illnesses kind of as a result of kind of longer life expectancy or just, other issues that may be popping up in their lives. And then looking at things like evidence-based clinical practice guidelines. So for instance, if you're looking at the number of meds someone should take, say for instance they have diabetes, they have congestive heart failure, previous MI, hypertension. It's very easy to see how the number of medications that get recommended by evidence-based guidelines gets pretty extensive. And one of the big issues I'll also mention here is that when you're dealing with patients, and especially if you're kind of coming from the family practice kind of side of things, is that oftentimes patients see multiple specialists. And so they'll have one doc writing for these 2 or 3 medications, you have another doc writing for these other medications, and oftentimes you may be the only person that kind of sees them kind of throughout this whole process here. And so what happens a lot of times is that one specialist will look at the meds that a patient's taking and say, well, someone else prescribed that, I don't want to touch it. And so you can find that because no one ever kind of goes back and says, well, should the patient be on this, if not, DC it. No one ever really does that. And so in a lot of cases, patients get just this this accumulation of drugs that they're going to be on, and no one ever kind of goes back and gets them off of any of them. And so I really encourage you guys, especially if you're kind of the primary care provider for them, is to go back and assess that, make sure things make sense. And if they don't, either call the specialist or make the changes yourself, because it can lead to very significant effects on your patients in the long run. So again, looking at age and comorbidity, there's about an 8% increase in the number of medications with every additional disease state. So for example, patient osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD, they can be on 12 different medications, no problem, 5 different times per day. Okay. Again, you'll find that changes occur over time as far as evidence-based guidelines, but usually they end up, in a lot of cases, adding more drugs rather than taking them away as far as recommendations go. And hospitalizations are a big thing too, because in general, when a patient goes into the hospital, they generally come back out with more prescriptions than they did when they came in, either for short course therapies for things like an infection or something, or it could be, lifelong medications they may be on after leaving the hospital. So it's really important to kind of assess their medication list to make sure that, hey, does everything make sense still? Is there anything that we need to change? Big consequences of having polypharmacy are going to be things like increased risk for adverse drug reaction. You can see things like falls are going to be a big risk. So fall risk is one thing you should always assess in your elderly patients, because medications can cause sedation, they can cause hypotension, leading to orthostatic hypotension. Lightheadedness, decreased alertness or confusion, all these things lead them to be more at risk for falls. And when they have a fall, they're more likely to have a fracture, and this can lead to major increases in morbidity and mortality. So we really like to prevent falls whenever possible. And then also you may see issues with decreased compliance. As you make a medication regimen more complicated or add more meds to it, you're going to find that it's more difficult for patients to be adherent to that, and thus the compliance is going to go down. And again, it always happens. It's hard for a lot of people to even take one medication one time a day. Imagine taking 12 different medications 5 times a day. It can be very, very difficult. In addition, just a complex dosing schedule, looking at the economics of all the medications that they're on. Sure, you may have prescribed them the latest, greatest drug that's out there, but if it's brand name and very expensive, patients may not be able to afford it. And so if they can't afford a medication, they sure enough are not going to take it. They'll either won't buy it at all, or they may skip doses, maybe take it every other day instead of every day. And some other issues include things like lack of support. So having a caregiver that can make sure that patients are taking medications appropriately, especially when they have some cognitive defects, can really make the difference between whether or not they're going to be compliant. Okay. Visual impairment can be another big thing. If patients can't see the right drug that they're supposed to be taking, or make sure they're taking the right dose, that can certainly impair it. So think about things like insulin pens. Oftentimes patients have to dial in the dose that they're going to be administering to themselves. If they can't really read the number that's on the dial, they're not going to be able to administer the right drug or the right amount of drug, and that can lead to some issues there, either hyper or hypoglycemia in those cases. If patients cannot swallow medications appropriately, they have some issues either secondary to, say, like a stroke or some other issue that can lead to problems there getting the medication. And then with a lot of patients, them having kind of frequent hospitalizations and frequent healthcare encounters, IV access tends to be much more difficult. As you try to use the same veins over and over, you're going to find that scar tissue develops, and they can end up losing veins pretty quickly there. So that can be a problem. And then just the willingness for a patient to adhere to treatment. As they get older, does it make sense for them to worry about their blood pressure quite so much? Or if they have a terminal illness or something like that, do they really care that their diabetes is under control when something else might be the cause of their demise before then? And so you really have to make an effort to kind of communicate with the patient, kind of find out what their priorities are, and make sure that the treatment plans are going to kind of line up with that. So in regards to that, end of life, we kind of consider that to be a patient that has less than 6 months to live. And again, you really need to prioritize and kind of tailor their treatment plan to what's best for them. And usually this is going to be more of a focus on quality of life rather than quantity of life for these end-of-life patients. So you're kind of looking at a graph of this, of some of the chronic disease state. Say for instance, you're looking at the patient and the family here in kind of this first stage, and here we're going to have the death of the patient. And what you see is that as the disease progresses, kind of early on you have the onset and the diagnosis of a fatal or terminal disease, the cancer or something like that. Initially, early on, the treatment goal is going to be to extend life, right? So we want to increase quantity of life at this point. But as the patient gets closer and closer to death, you're going to see that life extension is not either going to be possible, or the treatment is going to be so bad that it outweighs the potential benefits there, right? For instance, with chemotherapy, patients feel terrible when they're on chemotherapy. And so, you might get an extra month of life out of using this chemo treatment, but that extra month is going to be miserable. It may not make sense for the patient to do that. And so this is why you have an increasing reliance on palliative treatment, which means pain relief, improving quality of life. And so you're going to see a bigger and bigger focus on this as the patient gets closer to death. And then, of course, after that point, you're going to see where the family is going to be more focused on trying to help support them in their time of grieving. So looking at geriatric pharmacology, looking at some of the age-related changes you're going to find occur, cardiac status. Typically, patients get more hypertensive the older they become. You're going to find that the vessels end up becoming less pliable, and they're going to be more likely to be more stiff, and thus you can see increased pressures there. Usually, left ventricular ejection fraction is going to go down over time due to some kind of chronic changes occur there, and typically you'll see some decrease in heart rate in general. Renal-wise, this one's much more important for our purposes from a drug standpoint, is that you're typically going to see decreased renal mass. You're going to see decreased renal blood flow to the afferent artery, and that's going to be where blood flow is heading into the glomerulus, and so you're going to see a decrease in their glomerular filtration rate. So again, we're not going to be processing as much fluid through the kidneys. We're not going to be able to clear the blood of as many waste products and drugs as we used to be able to. And then also, in addition to that, you'll find a decreased ability to maintain acid-base balance. The kidneys are very important for either secreting bicarbonate or hydrogen ions in order to maintain acid-base, and so if they can't do that, then you can find issues where patients may be more likely to become acidotic or alkalotic. You can see here on this picture kind of the age-related changes that occur naturally over time. So you can see percent of function remaining, and then on the x-axis here is going to be age. So you can kind of see you're starting at 100%, say like in your early 30s, but you can start to see things like maximal breathing capacity. Lung function is going to go down over time. Looking at their GFR, or their renal function is going to go down over time, and cardiac function. Every patient's going to be a little different, especially depending on their disease states, but you expect these kind of declines to occur, and that's why we monitor for things with like laboratory testing, and we can make sure we can adjust things like their medications kind of proactively to make sure they don't get too much on board or too little on board and end up becoming either toxic or subtherapeutic. So look at some normal age-related changes that occur with their kinetics. So GI-wise, you're going to find that elderly patients, as far as the stomach and the duodenum, they're going to have decreased hypochloric acid or hydrochloric acid secretion and decreased pepsin. So you can end up seeing less digestion of food products that are coming through the GI tract, decreased gastric emptying, may have issues with absorption in the small intestine, decreased motility and constipation within the colon, and then also decrease in some enzyme being released from the pancreas, so things like lipase and trypsin, which are useful for breaking down fats and proteins, respectively. And then as far as the liver goes, you can certainly see declines in function there where you have decreased blood flow going through the liver, thus less things can be processed through and metabolized, less elimination, and liver mass or the size of it can actually go down as well over time. Looking at absorption, usually you don't see any kind of major changes, but the biggest things you can run into are going to be with certain dietary changes and that leading to drug interactions. So for instance, if you were to have a patient, we frequently recommend the elderly patients they drink lots of milk, right? Because it has calcium, vitamin D, and it's good for their bones. But if you have certain medications that can bind with those, like fluoroquinolones, which are a type of antibiotic, you may have decreased absorption, and thus the infection may not be cleared very well. Okay. Looking at OTC medications, they may be starting to take more of these, so things like laxatives for constipation, or if they have gastric reflux, maybe taking things like antacids like calcium carbonate or Tums, in which case they need to disclose that sort of thing. You need to make sure you ask about those kind of questions for these patients, because a lot of times they may not disclose over-the-counter medications when you ask about medication lists, because they don't necessarily make that connection that these are actual drugs. And so that that can lead to things like they have unexplained diarrhea, and we may not have realized that they've been taking these laxatives, or they have decreased absorption of certain things, and it could be related back to antacid use. So I'd like to ask those questions just to be complete when we get our medication history. Looking at, you can have impaired gastric emptying, especially in diabetic patients, due to some of the nervous tissue damage that occurs to the GI tract. So that can lead to things like gastroparesis, where patients are not able to process food through the GI tract, and you can sometimes have them develop vomiting because they have decreased gastric emptying, and so you can end up seeing kind of like vomit of food that looks like it hasn't really been digested yet. The food's kind of still in full pieces almost, and so that can be one thing you can see with those diabetic patients, which may impede absorption of certain medications. Looking at their drug distribution, typically you'll find patients will have, as they get older, they're going to have more fat tissue develop and less muscle mass. So typically they'll have a reduced lean body mass. They'll have a reduced body water, which can affect the vomit distribution for several different types of drugs. So things with high lipophilicity, you can see increases in vomit distribution due to increased fat tissue. Patients who are taking hydrophilic medications may see a diminishment in vomit distribution due to that body water going down, more that drug is being kind of kept within the plasma. So again, looking at body water, you can see the difference here between younger to older patients. Lean body mass, so again, it's kind of the fat-free mass is going to be going down. Body fat is typically going to be going up. Looking at things like serum albumin, so it may not be producing as many proteins, and then looking at kidney weight, which kind of can correlate with function, and then also hepatic blood flow certainly be going down as well. So other things you can see in addition to having lower albumin stores that can affect the ability for drugs to bind to those proteins as well. So patients with kind of chronic malnutrition and poor nutrition intake, they're going to have typical decreases in serum albumin, which means there's less proteins around to bind to those drugs, which we know can affect vomit distribution, affect the amount of free drug that can go around and bind to the receptors. Mostly going to be affecting things like weak acids, primarily because that likes to bind to albumin more than anything else. Sometimes you'll find increases in certain proteins, like this alpha acid glycoproteins that can have some effect to transporting certain drugs. It'll have more binding in those cases. So again, that can affect that free fraction, either leading to potentially more toxicity if you have a higher free fraction, or less efficacy if you're having a higher fraction of that drug being bound. Looking at drug clearance of the kidney, typically you'll see a pretty steady diminishment in kidney function as patients get older. But you may find that their actual serum creatinine increase is not going to be proportional to the decrease in their creatinine clearance. So for instance, if they have less muscle mass or if they've had like an amputation, they may not be able to produce as much creatinine as what they used to be able to, right? So even though their kidney function is actually going down, they don't have as big of an increase in their serum creatinine, which may lead you to overestimate what their actual creatinine clearance is and lead you to think their kidneys are working better than they are. In addition to this, you can see prolonged half-life of drugs eliminated throughout the kidneys, increased risk of developing those kind of toxic concentrations. And again, we can find that very frequently their hydration status is a big factor here. It is not infrequent that you'll have patients come to the ER who are, say, like in a nursing home, and they end up getting sick. They were not being hydrated appropriately, and that can lead to some significant accumulation of drugs due to a decrease in kidney function. And so I've seen several patients who end up getting very, very toxic from their medications due to this decreased hydration status. So it's really, really important that they monitor their fluid intake to make sure that stays appropriate. So again, just giving you an idea of how we're going to be evaluating that creatinine clearance in these patients. I know we've looked at this previously, but if looking at these patients, as patients get older, you're going to find that this gets less and less effective. Usually Cockcroft Gall is going to be for more healthy adult patients in a lot of cases, but depending on when their age is going to be a big factor here. So again, the bigger the age, the smaller this difference is, the smaller the creatinine clearance is going to be. As they get increased weight, hopefully they're going to be making more creatinine, but what you'll find is with really obese patients, they have a very high amount of adipose tissue, which is not really going to be contributing to their renal function. So that can lead to some overestimation of renal function for these heavier patients. And then obviously looking at their serum creatinine. So again, if patients are not producing as much serum creatinine as they should be based on their decreased muscle mass or based on amputations and things like that, you have a tendency to overestimate what their renal function is, because as the serum creatinine gets smaller, this creatinine clearance gets bigger, right? So overestimating, thinking they're clearing drugs better than they actually are. And so in some cases, you're going to look to other equations. So for instance, we have this MDRD equation, so modification of diet and renal disease. This was studied more in older patients who have kidney issues as well, and so it's able to basically have a better idea of what their actual GFR is. And we'll take into account other things like if the patient is black or if they're female. That way they can try to make the equations accurate as they can. Looking at drug clearance within the liver, mentioned that as blood flow is going to diminish, you're going to have less delivery of drug to the tissues or the liver for it to be able to be metabolized. That can be a problem. But you generally find, as far as first pass metabolism and bioavailability goes, is that you may have some decreased function of phase 1 reactions like our CYP450, and you really should have minimal changes in phase 2 reactions. So really not a whole lot of change there. The major factor for decreasing metabolism is going to be this impaired liver blood flow. So less blood flow, less metabolism of the drug is going to be occurring. You are more likely to see a lot of interactions here, especially with the CYP450 system. As their number of medications goes up, you're more likely to see interactions where you're inhibiting certain enzymes or maybe you're inducing them, which can lead to either higher or lower levels of drugs and lead to toxicity or subtherapeutic effects. So the question, oftentimes comes up, looking at pharmacodynamic changes, is are these geriatric patients more sensitive? More likely than not, it's not necessarily that they're more sensitive to these effects. It's going to be an issue, one, of altered pharmacokinetics. So are their levels higher based on changes in renal function and hepatic function and whatnot that lead them to have higher blood levels, which makes them seem to be more sensitive when really they're just holding on to more drugs? Or it could be due to these lessened homeostatic responses. So for instance, when you're going from a sitting to a standing state, you typically will have a drop in blood pressure, which your body responds by trying to increase peripheral resistance and increase the amount of blood flow going to the head, right? Well, you may find that older patients are going to have an impaired ability to compensate for that just at baseline, and that drugs can actually make this worse. So they tend to have more risk for things like falls and dizziness related to these kind of effects here. But some examples of these impaired homeostatic responses, things like not able to increase cardiac output at the same rate that a younger patient would, or that postural hypotension I just mentioned. Some patients that are older, they tend to have more poor temperature regulation. So, it's like whenever I go to my parents' house, they're starting to get up in their 60s. The house is always super, super hot because, again, they have poor temperature regulation. They tend to get colder than younger patients might. And then typically as they get older, especially with diabetic patients, their fasting blood glucose should increase over time. So just to give you a few examples of specific drug class effects that you can see changes in elderly patients. So looking at sedative hypnotics, many drugs seen in this category can include things like your benzodiazepines that we use for anxiety or for sleep. You can find that some of the half-lives of these drugs can be increased by 50 to 150%. So they're sticking around much longer than they would be in otherwise healthy patients, which can lead to big effects for causing dizziness, ataxia, increased sedation. All that can be very problematic, which means they have more risk for falls. Altered mental status. This is a really big thing where you think your grandpa or grandma is just going senile, or they're having worsened dementia, when really you could probably link it back to medications and not having their doses adjusted appropriately, right? So again, always look at their medication list when you're assessing a patient for new onset altered mental status. Not only that, certain drugs can have active metabolites, so they get broken down in the liver to these active metabolites that can also have their own therapeutic effect. So that can be really problematic, and why we like to choose drugs that do not have active metabolites for these elderly patients to avoid this issue here. Another example, analgesics or opioids specifically, you may see that patients tend to be more susceptible to respiratory depressive effects. They can have accumulation of active metabolites, which can be really problematic. For instance, there was a drug on the market called propoxyphene. Darvocet or Darvon was the brand names for that drug, and it used to be used very frequently. It wasn't really a good drug necessarily. The evidence out there for its use was not great. But what they found was that there's an active metabolite called norpropoxyphene that these elderly patients could not clear because of poor kidney function. So these patients ended up having a buildup of norpropoxyphene due to poor kidney function, and they can end up developing seizures and arrhythmias due to this. That actually led for the drug to be removed from the market. So again, can't get any more because we know that in these elderly patients that it was just the risks were too high versus the benefits, which were pretty minimal. Looking at antipsychotics and antidepressants, just some examples there. Lithium being a very common drug we use for bipolar disorder. Probably used less frequently nowadays since we have a little bit safer drugs available. But this one, its clearance is dependent on renal function. So as that goes down, you end up seeing buildup of lithium levels. And then not only that, but if you were to put a patient on a diuretic, cause them to have increased diuresis and increased micturition, you can see increased accumulation of things like lithium, which can all lead them to become very, very toxic. As far as antidepressants go, you'll find that a lot of our older agents, like our tricyclic antidepressants, they tended to have bigger risk for things like falls and altered mental status. So luckily nowadays we have newer agents, which are much more preferred because they have a much larger therapeutic index. So this is where we get our selective serotonin reuptake inhibitors, things like your SSRIs is another name for that. They tend to have a much wider therapeutic index, so it's much more difficult for patients to kind of get close to that therapeutic or that toxic level, as we would see with some of our older drugs. And then looking at cardiovascular agents, again, patients as they get older tend to become more hypertensive. And so with antihypertensives trying to cause vasodilation, you can see increased risk for things like more orthostatic hypotension. So again, more risk for falls as they go from sitting to standing or laying to standing. And then also with your diuretics, you're more likely to see electrolyte imbalances. We'll talk about this in detail when we get to pharm, but certainly you'll see that having these electrolyte imbalances can worsen certain disease states, can lead to arrhythmias in some cases. So again, one of the things you definitely want to monitor by looking at their electrolyte panel over time. And then antiarrhythmics, patients who are on antiarrhythmic for arrhythmia, obviously, are going to have poor hemodynamic reserve in a lot of cases as they get older. And so because they are also at risk for having more electrolyte imbalances, you can end up seeing them much more likely to develop arrhythmias. One of the things you will learn in pharmacology is that any kind of antiarrhythmic used to treat an arrhythmia can also cause arrhythmias themselves. So when you have extended half-lives of some of these drugs like quinidine or lidocaine, they can stick around for much longer and are much more likely to cause an arrhythmia. So looking at the number of adverse drug reactions these geriatric patients can have, again, the larger the number of drugs they're on, the more likely they're to have an ADR. And so just with a single medication, say a patient maybe only have a 10% likelihood of developing an adverse reaction, that goes up to nearly 100% by the time they get up to close to 10 medications. So it's very, very likely. A lot of times patients may not realize what they're experiencing is an adverse reaction due to a drug, which is why it's very important to ask questions. Ask them, if they're on a particular drug that causes, say, itchiness. Like ask them, hey, do you notice you're more itchy than normal? They may have brushed it off as just being unrelated when it totally could be. And then not only that, but you're also looking at, their OTC drug use, so things they're getting without a prescription, herbal medication use. Really, really important that you factor that in, and that they are being honest with you and being forthright with those medications. Otherwise, they're taking them and not telling you. You may be prescribing a very potentially dangerous combination without you really even noticing it. So looking at some of our adverse drug reactions, again, some of it could be related back to prescriber errors. So that's why it's really, really important that when you're prescribing a drug to be taking into account age-related changes that can occur, especially over a period of time. So again, you start a patient on a drug year 1, their renal function may be much different at year 5 or year 10. And so the drugs need to change along with that where appropriate. Otherwise, you can bleed into pretty big toxicity. Again, due to patient compliance errors, if they're not taking medications like they're supposed to, or they're self-medicating, that can, of course, lead to some issues there, increasing risk for adverse drug reactions. And then finally, seeing multiple providers. This is kind of going back to that problem I mentioned before, where patients are seeing multiple specialists. Everyone's prescribing different drugs for different conditions, and thus you're seeing issues where they can, if the right hand's not talking to the left, you can run into some communication errors there and more likely to see issues. And then in some cases, patients may not even recognize certain drug products as actually being a medicine. So for instance, BC powders or goodies powders, this tends to be more of a kind of a southern thing than a lot of people from the north that haven't really heard of these before. But essentially, these are powdered aspirin products that come in these little paper sachets that you will put into your drink, water or juice or whatever, and will allow for a very rapid absorption of aspirin. Well, some patients don't actually realize that this is an aspirin product in the first place, and so they may take an aspirin for the heart, baby aspirin, and then they also will take these whenever they get a headache, and not realize the risk they are having of developing toxicity. And so, for instance, we had one elderly patient who knew that he should probably take one of these every time he had chest pain. Right? He didn't know it was aspirin, but he knew that when you ever have chest pain, you should probably take a BC's or goodies powder. So this guy, he would end up taking, BC powder every single time he had chest pain. So eventually he ended up having so much chest pain, he called 911. 911 arrived. They say, hey, you're having chest pain. Do you take aspirin? The guy says no. So they give him, they give him another dose of aspirin. Guy gets into the ER. EMS did not communicate. They gave the guy aspirin, so then the resident ended up giving it to him as well. All of a sudden, the guy's complaining of tinnitus. He's complaining of having, his respiratory rate's going up. These very classic signs of aspirin toxicity because he didn't realize that the BC powders and goodies he was taking was indeed an aspirin-based product. So again, that's why it's really, really important to ask those questions. And if you don't ask them, you're unlikely to get the answer. So just some questions you can consider asking when you're doing kind of the structured history of intake of medications. When you're doing a medication reconciliation, it's really important to do this. So obviously first list off all the medications, making sure they are taking it as prescribed, so have them quote back to you the doses they're taking, how often, the dosage form, ask them about things like side effects. If they're not taking it like they should be, why are they deviating from that, or if they're not taking it, these are where you can find out financial issues or certain adverse drug reactions that make it intolerable. And again, make sure you're having a curious and non-judgmental kind of conversation with them. If they're not taking it, don't shame them for not taking it because they may have a very good reason to them. But it's important that you kind of encourage their honesty rather than them being worried about you chastising them for not following your instructions, right? So then ask about any other medications not on the list. Find out if they're taking medications from their sister or from their neighbor, and then ask about over-the-counter non-prescription drugs as well. Also ask about herbal medications, vitamins, homeopathic drugs, if there's any kind of like home remedies they may be taking, especially patients who are from different countries may have different types of medications that are not available here in the U.S. So think about like patients who may, their family practices, traditional Eastern medicine or Ayurvedic medicine if they're, say, from India or somewhere. So lots of different things that could be, the patient could be taking, they may not be forthright with unless you ask. That's about things like, they're using drugs on demand. So either illicit drugs, some patients will self-medicate with things like marijuana or things maybe getting from outside of the country. Ask about drugs they are no longer being prescribed. This is a big problem where patients will continue taking medications presumably forever, as long as they never get the clue that, hey, this medication is DC'd. Sometimes they don't get that message, and so when they call up to the office, they run out of refills and say, hey, can I get a refill for this? If the documentation is not very good, someone else could come along and say, yeah, refill's authorized, and the patient continues taking it much longer than what you'd ever anticipated them to do so. So make sure that communication occurs there pretty well. And then also make sure they check expiration dates on all their products. Make sure they're not taking anything that could be less effective due to it being expired. Some of these patients will have drugs that have been sitting around since the 80s. It's probably not the best version for them to be taking. Ask about things like, are you taking medications independently? If not, like who's helping you? So you can kind of find out, are they able to use things like their inhalers appropriately, or can they inject their insulin appropriately? Maybe they need some kind of caregiver to kind of help out with this. Ask about any kind of dosage systems they may be using. If they have like any kind of pill reminders or anything that could be useful for helping them to increase compliance. And then you want to be assessing for things like any problems with the medication, so any adverse reactions they may be noticing. Then you can also use some prompting questions to be like, are you experiencing this based on the drug they're taking, or this other side effect? And then inhalational therapies are a big one. So what kind of system are they taking? Any problems? You run into this mostly with patients who have either osteoarthritis or rheumatoid arthritis, or just the inability for them to coordinate use of the inhaler with them actually inhaling it. So again, assessing whether or not they can use the drugs appropriately or not is important. Same thing for eye drops. Are they able to administer it appropriately? And that's what they do if they forget to take their medication. In some cases, it's appropriate to take a double dose. In other cases, it's not appropriate. So make sure they know what to do should they miss a medication. And then, of course, any other kind of miscellaneous comments or questions. Here's an example of some pill reminders. Obviously, things can be much more complicated or much more technologically advanced than this. So there's applications, there's reminder apps, things you can use like that to kind of help the patient out. These are kind of the most common ones you may run into. So again, looking at the application of this stuff, so there's lots of obstacles to compliance and making sure elderly patients take their meds like they're supposed to. For one, look at the expensive medications. So for instance, if you're prescribing something for arthritis, a newer NSAID may cost hundreds of dollars, whereas aspirin or ibuprofen can be much more cheap, maybe much more appropriate for that patient. So again, think about what they can actually afford. This is where you want to be familiar with things like the $4 list at certain chain pharmacies. If there's anywhere they offer free medications, these are very important to know, and especially in conjunction with any insurance they may have. Try to do medications without mixed dosing intervals. Try to make sure you're going to be trying to, if you can get everything as once daily, great, or twice daily, it's going to be the best thing for them, so that way they can just take the same thing at the same time and be done with it. In some cases, maybe dealing with this kind of intelligent non-compliance where the patient may be saying, well, I can't really afford this stuff. Let me just go ahead and take it every other day, but tell the provider that, hey, I'm taking it like I'm supposed to. This is really difficult to determine. But again, if you can say things like, hey, I noticed I put you on this drug, but their blood pressure isn't really coming down. Is there anything going on? Like, are you sure you're taking medications every day? Again, remember to be curious and not judgmental. That way you can try to make sure that you encourage them to be forthright with you, and not that you're going to get them in trouble, so to speak. And of course, can the patient physically take the drug? Again, with inhaler systems or injectables, make sure they can really physically, mentally keep up with actually taking this. Otherwise, they need some help to do so. All right, so that's it for the geriatric section. Now we can move on and start talking about the children. So Why is treating pediatric patients so different? Well, for one thing, they're a very heterogeneous population, meaning that dealing with a 2-day-old is much different from dealing with a 2-month-old, and is much different from dealing with a 2-year-old, right? They undergo kind of constant physiologic changes, and one of the big things you run into, especially with pharmacology, is that you have limited kinetic and pharmacodynamic data in children. It's very difficult due to the fact that these kids are a at-risk patient population to do adequate studies with them. There's a lot more kind of red tape you have to go through because ethically, they are very, very sensitive, very at-risk kind of population. So it's hard to get that data, and then when we don't have data, we extrapolate it back from adults. And as you'll realize, pediatric patients are not little adults. They should never be considered so. And so in some cases, when we try to back extrapolate that data, we do that with kind of varying degrees of success depending on the situation. So it's important to make sure we use the correct lingo when we're talking about pediatric patients. First thing going to be gestational age, which is a maturity at birth, essentially. Usually it's based on dates. So for instance, the last menstrual period, and then also could be based on physical exam if you weren't sure of the last menstrual period, based on the size of the fetus. That could also give you some idea. Postnatal age is going to be the chronological age of the patient after they were born, and then the postconceptional age would just be the two gestational and postnatal age added together. I don't really see postconceptional age used too frequently, but certainly we use the first two pretty commonly in peds patients. So preterm would be considered underdeveloped neonate, and that would be one that is birthed at less than 37 weeks gestational age. Full term would be anywhere between 37 and 42. Post-term would be greater than 43 weeks gestational age, and then a newborn or neonate we would consider to be in that first kind of 28 days of life, or that first 0 to 1 month of age, and then an infant would be anywhere from 1 to 12 months of age. You'll probably hear me kind of talk about these interchangeably, and that I may refer to an infant being in that first month of life or so, but technically a newborn or a neonate is going to be strictly that first 28 days versus an infant just being the rest of that first year. Toddler would be any kid that is 12 to 24 months of age, young child being 2 to 5 years, older children being 6 to 12 years of age, and then finally adolescents 13 to 17. You'll tend to see that as patients get older and they start to get to that adolescent age, especially when they start to get towards the weights of an adult, that you're going to find that we treat them very similar to adult patients, because by this point after puberty, they're pretty much functionally the same as most adult patients, with some exceptions, but in general, you're going to find that they tend to be from a maturity standpoint, maybe not in their behavior, but certainly from their physiology, they should be pretty close to adults. So just to give you an idea of some of the things we'll talk about as far as the kinetics and how they change with pediatric patients, the first thing we want to talk about are going to be things in regards to absorption. So we're going to look at things like the GI function for the patient, and also development of the integumentary system. So looking at absorption of drugs, we'll find that the physiochemical characteristics of the drug and the formulation are going to be important in describing what type of absorption you're going to have. That includes the molecular weight of the drug, so the bigger the weight of it, the larger the molecule, the harder it is to be absorbed. Particle size can be important here, so the smaller particles tend to have bigger surface area, or more surface area that can be absorbed. pH of the solution that the drug is in, and the pKa, and then also the dosage form. And so you're going to find that based on different changes within the peds patient, you can have anatomical, physiologic characteristics of the sites of absorption. So whether you're talking about the stomach or the small intestine, can be affecting absorption to a great degree. So looking at the two major determinants of GI absorption for these drugs includes looking at the gastric acidity and then also the gastric emptying time for the children. And so these differ pretty greatly between infants, especially in that neonatal period, up through the adult patients. So looking at gastric absorption based on pH, we will see that based on that pH based on pH-dependent passive diffusion. So again, kind of going back to our Henderson-Hasselbalch equation, remembering that like dissolves like. So again, weak acids get absorbed better in acidic mediums. Weak bases get absorbed better in basic mediums. But basically, we're going to find that, especially in preterm infants, so those that are born, less than that 37 weeks gestational age, their pH is typically higher. Very early on in the first few days of life, you're going to find that gastric acidity is going to be pretty, or gastric secretion is going to be pretty poor because it's going to take time for them to start kind of producing their own stomach acids. Also, you're going to find that pH is going to be a lot higher in full-term infants, even for the first 3 days, due to the fact that they have been ingesting some of the amniotic fluid from the mom, which generally has a pH of around 6 to 8. Okay. You're going to find they start to really kick up their acid content during this first few, about the first week of life or so, and then tends to decrease back down a little bit. So again, by the time they're about 3 months old, they should be at the lower limit of around adult values as far as gastric acidity, and trying getting that gastric pH down to around 2 or so. So again, that means that for acidic drugs, you're going to have an increased amount of ionization, which means they can have a harder time being absorbed, especially when the pH of the stomach is elevated. And then for basic drugs, you can actually have increased absorption, which can be a good thing for some drugs. Next, we're going to look at gastrointestinal emptying time with this GIT, and so this is going to help to determine rate of absorption. And what you'll find is that the gastrointestinal emptying time is going to be much slower in infants less than 6 months of age. It takes time for them to be able to process things through the GI tract, and so this can be associated with many factors. So, for instance, if they have some sort of congenital heart disease, which may decrease blood flow to the GI tract, that can also slow down GIT as well. Can be affected by the type of feeding that they're receiving, whether it's breast milk or versus formula, and then looking at their gestational and postnatal age. So usually as they are either more immature when they're born due to decreased gestational age, or the younger they are, they typically the slower you're going to see this be. So what you'll find is a shorter transit time. So again, if you were to have increased GIT, you're going to end up finding decreased duration of drug contact with, say like the small intestine. So it's not going to be absorbed as well. And so if you were to give them like an extended release formulation, they may find you have actual incomplete absorption that occurs there. And so this can account for, inter-patient variability as far as what kind of serum concentrations you were to get, even though you may have given them the same amount of drug based on their weight. So again, other extra-oral drug absorption, some of the things we're going to look at here include things like looking at muscular blood flow for intramuscular administration of drugs, looking at mucosal permeability, and also skin permeability. So typically for neonatal patients, again, that first month of life or so, you're going to find they have decreased muscular blood flow. So we'll see this will have some effects here, and we'll look at in just a second. And again, you're going to find increased permeability in the mucous membranes and also in skin permeability. So looking at intramuscular absorption, you're going to find this is dependent on several factors. So this can include the blood perfusion to the area of injection. So again, if you don't have any blood going to the area where you injected it, typically you're not going to have a lot of good absorption. Okay. Also depends on how well the drug is able to penetrate through the capillaries to be absorbed in the first place. And then again, the apparent volume into which the drug has been distributed. So we're going to talk about volume of distribution in infants. We're going to find that, especially in the neonatal period, they're going to be basically big bags of water. So we're going to look at why that is in a minute. But they have a very high amount of body water compared to like an adult patient, and so this can affect the volume of distribution pretty significantly. So neonates and infants typically differ from older kids and adults because they have less blood flow to the muscles, so that impedes absorption. They typically have an increased percent of water in the muscles, so this can increase the apparent volume of distribution for drugs that have a high hydrophilicity. And this can also be impacted by the amount of muscular contractions. Typically, they're not very active. They're not moving around a lot. That decreases the amount of blood flow going to the muscles, and that can also decrease the rate of penetration. And the other thing that kids have as well, especially infants, is going to have this peripheral vasomotor instability. So because they can't really regulate their temperature very well, having blood flow around the muscles being controlled very well is just not happening yet. And so it takes time for them to really develop that to allow for more consistent absorption from the intramuscular route. So looking at rectal absorption, you're going to find that they have very good bioavailability of many medications due to the fact that the rectum is going to be very well vascularized. There's lots of blood flow there, and also they have very thin mucous membranes, so you can have very good mucosal translocation here, which is why we end up having things like acetaminophen suppositories are given pretty frequently, and other types of suppositories due to good absorption. As far as neonates and children, they can also have an increased amplitude of rectal contraction, so this can actually be problematic because if they expel the drug before they've had time to absorb it, that can lead to decreased efficacy, and you may need to redose the patient potentially. So one other way we can give drugs for pediatric patients, because I don't know if anyone's ever tried to give or start an IV on a pediatric patient. I know I certainly have not, but what you will hear is that it can be very difficult. They have very small veins. They can be very difficult to get a hold of, and especially if the patient's moving around on you, because again, they probably don't want to be stuck by a big needle. One of the things you can actually do is to give intraosseous medication. And so basically, this would be by sticking a large needle through the intraosseous space base into the bone marrow. So you can kind of see an example here. The tibia is probably used most frequently in peds patients that I've seen, but you could use other areas like the humerus or the sternum. But this is really good for emergent medications or emergent situations where you need to give drugs right now, or you need to give fluids or blood, because basically the marrow acts as a big non-compressible vein and allows for good absorption of medication through this route. It's very easy to get a hold of because, again, you're just kind of jamming a needle straight into the bone versus trying to get to a very small vein. As far as percutaneous absorption goes, so again, going through the transdermal route, you're going to find that kids typically have an underdeveloped stratum corneum. That means the thickness of the stratum corneum is going to be inversely related to its absorption. And so you can see big issues where they have very, very good absorption due to this. And so one example of this would be hypothyroidism from betadine. Betadine is an iodine-based antiseptic that used to be used for cleaning patients. And so they've actually found that they were able to have pretty good absorption of this, and what you'll find is that having too much iodine on board leads to hypothyroidism. It can actually impede the ability to make thyroid hormone. That's one of the reasons why we don't use that for kids, because they absorb it so well. Also, you're going to find that the skin is very well hydrated and very well perfused, and so that means that also the more hydrated the skin is, the better the absorption is going to be there as well. And not only that, but based on their body surface area, compared to an adult patient, they have a very high amount of body surface area compared to adult patients, given their weight. This means that even though you're covering a very small area, it can be quite large for them on a percentage basis, which means you can have toxicity that can develop from absorbing too much drug. So for example, if you were to give an antihistamine lotion on the skin, they can develop seizures and anticholinergic toxidromes from this. Patients who have been bathed with isopropyl alcohol or isopropanol had developed hypoglycemia and lethargy from this. So again, just assume that they are much more likely to absorb things from that transdermal route as compared to adult patients. Now, looking at volume distribution, again, we're relating this back to not only the dose of the drug that we're giving, but also the concentration that results from this. This tells us how far that drug is going to be distributed throughout the tissues, right? So what we can find, looking at distribution site, is that typically patients who are very young typically have an increased amount of total body water and a decreased amount of body fat. So especially when you're looking here in the very early stages, this can affect volume distribution very significantly, as we're going to see here in just a minute. Basically, this is going to be affected by the lipid solubility of the drug, the plasma protein binding, the tissue binding, as we've seen before, and then peripheral site distribution. So basically what you're going to find is that distribution can be changed in a lot of cases, especially when they're critically ill. So they're having a large amount of third spacing of fluids, causing edema, or burn victims. All of that can lead to changes in volume of distribution for a lot of these drugs. So looking at the newborn infant, you can find that about 70 to 75% of their body weight is just water. So again, I mentioned they're basically just big bags of water, and you're going to find that they will have an increased extracellular water component as compared to adults, about 40% for them versus 20% for adults. They also have less fat tissue and less muscle tissue. So that means, as a result, they have an increased volume distribution for many hydrophilic medications. So basically, they have a larger bucket to fill. So as compared to an adult patient, that means in order to get the same concentration, because remember that if you were looking at the C0 equals dose over VD, as their volume distribution is higher, again, that's in that denominator, you're going to find that you have to give a larger dose on a milligram per kilogram basis to get the same serum concentration as you do to an adult. Because their bucket's bigger, their drug is distributing out further, we need to give them a larger dose to make the same concentration. So an example of this is gentamicin, which is a very good gram-negative antibiotic, and it's very water-soluble, so it's very hydrophilic. And if you're looking at the volume distribution on a liters per kilogram basis between neonates, infants, and children and adults, you see it's much higher in neonates due to their increased water content, and it gets lower and lower as you get older, and that water content goes down, your body fat goes up, all those different things. Now, that means that in order to achieve the same concentration, I have to give a much bigger dose in neonates than I do for adult patients. So, for example, for these patients, I would have to give 4 to 5 mg per kilo per dose. For neonates, for infants and children, only 2.5 to 3, and then for adults, maybe 1 to 2 mg per kilo. All of these, when given to patients via this dose, would achieve the same serum concentration. It's just a matter of what their volume distribution is. Right. So again, on a milligram per kilogram basis, neonates may need a larger dose, even though they're smaller patients in general. Also, you can find early on they have decreased plasma proteins, which means there's less protein binding. They usually is due to lower protein stores that they have there, which means you can have extra distribution of certain drugs due to this. Also, you may have some competition for those binding sites. So bilirubin is a really big one where you can have some interactions between certain drugs and bilirubin, especially in this first month of life. So one antibiotic we'll talk a lot about when we get to pharm is going to be called ceftriaxone or Rocephin. It's a very good kind of broad spectrum, gram-negative, some gram-positive killing antibiotic, but it binds to the same sites that bilirubin does on albumin. If you give ceftriaxone in the first month of life, it will displace bilirubin from the binding sites, cause bilirubin to go up, and one of the things you'll find develop is jaundice, so kind of a yellowing of the skin and the sclera, which can be problematic. So that's why we don't use that drug in the first month. After that, though, typically the protein stores are going up. There's enough binding sites for everything. You don't run into that interaction anymore. Another good example is phenytoin, which is an anti-epileptic drug or anti-seizure drug. And basically what you find is that it's about 90% protein bound in most cases for patients who have a normal amount of protein stores. For these younger patients, though, because they would have decreased protein binding, they end up having higher than just 10% free, as you would see in an adult patient, maybe say 15 or 20%, in which case, even though they look like they have a therapeutic concentration in the plasma, they could have an increased free fraction, which means they could be more likely to have toxicity. Okay, so you have to take all these factors into account when assessing the type of dose you're going to use and how frequently to give the medication. So looking at comparison between neonatal patients, infants, and children, looking at plasma albumin, you'll see this is going to be reduced most time, and then by the time they get older, it's going to be much closer to a kind of adult patterns. And just in general, you're going to find they have decreased or reduced total proteins here. So some of the factors that can affect metabolism here, we'll see that looking at increased gestational age and postnatal age both will increase metabolism. We'll look to see there's going to be some changes in hepatic blood flow. Usually if that goes up, metabolism will increase as well. Also looking at the size of the liver in addition to the quantity and quality of hepatic enzymes that are available. And then we'll see some things can decrease metabolism, so things like disease states like liver failure. And then also whether we are inducing or inhibiting our enzymes can also affect this. Looking at our phase 1 reactions, remember these are going to be things that are generally going to be altering the molecule to be more water soluble or to get it ready for phase 2 reactions in which we will actually add on some kind of functional group to the drug. But essentially here we're going to see that this is oxidation, reduction, hydrolysis, demethylation, oxidation being one of the big ones where our CYP enzymes are working. What you typically find is that for CYP450 activity in full-term infants, it's about half of that of adults. And so you can see that they'll have different rates of maturity as a patient starts to get older. For some other phase 1 reactions, things like oxidation, again, phenytoin being an anti-seizure drug, by 1 year of age, you can actually find that postnatal activity is going to increase 2 to 5 times that of an adult. So those patients, you may need to give the drug more frequently or at larger doses to account for this increased metabolism. Some other drugs, for instance, like looking at hydrolysis, so procaine and tetracaine, these are local anesthetics. Having hepatic and plasma esterase activity may be reduced in infants, leading to increased activity of the drug as it sticks around for longer. So just be aware there's going to be some changes there, and when you are looking at your drug references and they give different dosing for neonatal patients versus children versus adults, this is where they're coming from, is looking at the changes in not only the kinetics of the distribution, but also in the metabolism as well. So different enzymes mature at different rates, as I mentioned. Looking at CYP2E1, for instance, you'll find that within hours after birth, activity actually increases pretty rapidly. CYP2D6 can be detectable soon after birth. 3A4 and 2C enzymes are going to be present in the first month. And you may find things like 3A4 actually in young infants may actually see at adult levels, kind of what we've mentioned with the phenytoin. And then with phase 2 reactions, you'll just note that, again, they were adding on some sort of functional group onto the drug molecule, usually to either be excreted in the kidneys or potentially in the bile. And this is where we have things like sulfation, methylation, conjugation with either glycine or glucuronide. And so looking at specific pathways, you can find that some of them are going to be not so well developed, some of them will be very well developed. So for instance, with sulfation, metabolizing acetaminophen, we find that at birth it's very well developed, in which case kids can actually tolerate larger doses of acetaminophen than an adult patient could, making them more resistant to things like overdose. Okay. Another example of methylation for epinephrine, you're going to find that it can be a very well developed functional pathway at birth, you may find that it's not going to be really utilized a whole lot for the metabolism of drugs in adult patients. So again, you can find some pathways being much more prominent in peds patients versus adult patients. Another good example is glycine conjugation. For example, benzyl alcohol. It's a preservative sometimes we'll use in IV medications. And so during neonates, because we know they have any impaired ability to actually metabolize benzyl alcohol, we make sure we use preservative-free drugs for neonates. So one thing where we actually choose a different drug product just based on the fact that they cannot process that metabolite, or not able to metabolize that preservative. So then moving on to excretion, again, most drugs end up being renally excreted, and this can be dependent on things like the number, size, and quality of the glomeruli. The extent of protein binding of drugs, usually increased protein binding means less of it can be filtered by the glomerulus. Looking at renal blood flow, concomitant disease states, and then if they're going to be on any nephrotoxic medications. And then certainly looking at urine pH can affect reabsorption of drugs along with the urinary drug concentration. So looking at GFR in infants, we use serum creatinine as our surrogate for this, and typically you're going to find that infants are going to have an increased serum creatinine for that first week of life, and this is going to be due to the fact that you're probably measuring mom serum creatinine, and so we cannot use this as a very reliable indicator of what their actual renal function is for the first 1 to 2 weeks or so. But typically after they're born, first 1 to 2 weeks, you're going to see renal function start to improve, but obviously the more premature they are, they're going to have more immature kidneys, and thus their GFR is going to be down, right? This means they may not be perfusing the kidneys as well with having evidence of renal blood flow reductions, or they may just have very immature quantity and quality of those glomeruli. So as you can see here, looking at differences in renal function based on term infants, a preterm infant who's say less than 2,000 grams or 2 kilos, or very low birth weight baby, a preterm less than 1,500 grams. You can see here that 1 to 2 days postnatal age versus 8 to 9 versus 2 weeks or so. You can find that even for the really small preterm ones, they're still not even at 2 weeks at the same level as you would see for a term infant. And so it takes time for them to really start to mature the kidneys, because again, this is time that a lot of these premature babies would have been spending in the mom anyway, developing further. So they're kind of playing catch up from the time they're born, moving forward. And so that's why looking at the serum creatinine cannot be super useful for measuring what their GFR is, and a lot of time we're going to be looking at their urine output instead. So you can measure, how much their diapers weigh, and that kind of tells you how much urine they've produced. Basically, one of the things we're going to look for is anything greater than 1 ml per kilo per hour is usually considered to be pretty good urine output for these infants. And so you can see here how GFR changes as patients get older. Say around a neonate may only be around 30 to 40 mLs per minute versus by the time they're about 6 months old to 3 years old, they're around adult levels at that point. So it takes a little bit of time. And again, the more premature they are, the longer it takes to really get caught up to this point here. And so this can affect the half-life of drugs very significantly, especially ones that are primarily eliminated by the kidneys. So gentamicin, again, the example drug we're going to use here, for hydrophilic, almost entirely eliminated through the kidneys. And so what you'll find is that the half-life for immature infants, especially those who are born prematurely, are going to have a much longer half-life for this drug. So for instance, if they're a neonate less than 1 week, so this may be a term infant, around 3 to 11.5 hours versus, say, 1 week to 1 month, 3 to 6 hours. And then as you get older, very, very short half-life, maybe 1.5 to 3. Basically what that means is that for the younger the patient is, the longer the half-life is going to be, we have to dose that drug less frequently. So for example, for an adult patient, we may dose gentamicin every 8 hours, versus for one of these neonates less than a week old, we may be dosing it every 12 hours, or every 24, or even some cases every 36 hours, depending on how premature they were. So basically that means that, for these hydrophilic medications, we have to give a larger dose on a milligram per kilogram basis, but we give it less frequently because they can't metabolize it as quickly, or excrete it at least. So looking at tubular secretion and reabsorption, you're going to find that both of these are pretty significantly diminished in that first year of life. And so other things that can be affecting that renal tubular development is if they have any kind of impairment of renal blood flow. They may have decreased ability to really concentrate the urine very well. So you can see some electrolyte issues from there. And typically you're going to find lower urinary pH values. We know this can have an effect with reabsorption of certain drugs, especially the more acidic ones. They tend to be reabsorbed better at lower pH values. So looking at those diversity of drug responses, we can see that there's several factors going to be playing a role in here. So again, looking at the biological factors, so the sex of the infant, the age, disease states, the physiology, all that can be affecting how well they're going to be able to either metabolize or excrete these drugs. And then we'll find there's also going to be some genetic polymorphisms as well. So whether or not they have certain transporters are going to be either in increased expression or decreased expression. Sometimes they're going to have fewer or greater metabolizing enzymes available, and then certainly there's going to be some environmental factors that will be affecting this as well. So kind of all of these kind of play a role in determining what an infant's drug response is going to be, or child's drug response will be in the long run. So it's important to try to take all of these into account when you're prescribing a drug to make sure that we are dosing it effectively and that we're choosing the right drug for that patient. So again, another good example, I've probably mentioned this before, but looking at codeine metabolism. Codeine is an opioid that we use for pain control, and we do it because it gets converted over to morphine by metabolism through CYP2D6. So for instance, if we have a mother who has active CYP2D6 versus the child who does not, you may find that they can actually end up producing too much morphine for the child, and you can see some exaggerated response there. For children, you can end up finding that they will have either increased expression of CYP2D6, or they may have a decreased expression, in which case if they have too much CYP2D6, they are making too much morphine, and thus they end up having toxic side effects from that. Or if they don't really express enough CYP2D6, you end up having a diminished amount of morphine being made, unless the drug is not very effective at reducing pain, which means they end up getting a black box warning because there were some deaths associated with children who were making too much morphine, had respiratory depression, and died after having a tonsillectomy and adenoidectomy due to obstructive sleep apnea. So because of that, certain drugs may not be appropriate for children because there's just so much variability in their ability to handle the drug appropriately. So looking at some age-based or different dosing regimens, we can see age-based here. So for example, codeine, age-based just means you look at the age of the patient and you decide how much you're going to give based on that. So for instance, 2 to 5 years old may receive between 2.5 and 5 milligrams every 4 to 6 hours is needed. For a greater than 12-year-old, say 10 to 20. This is really easy to use, which is good for clinical practice, but it is going to also assume that it has every child is going to have the same maturation in their pharmacokinetic variables, so absorption, distribution, metabolism, and excretion. And of course, we know that's not the case. We know that many patients are going to fall outside of these norms, which basically means that we need to, oftentimes age-based dosing is not going to be appropriate for many patients. More frequently, what we use is body weight-based dosing. And so, for instance, with neonates and infants, you may see, say, 20 to 30 milligrams per kilogram per day divided Q12. Or for infants greater than 3 months, say 25 to 50 mg per kilo per day. And again, these changes are based on looking at their metabolism, looking at their distribution, in order to make sure we're getting similar serum levels. One thing to note here is if you're dealing with an infant or dealing with a child, dealing with a child, is that once you start to get to big enough weights where they start to come close to the adult doses, you don't ever want to exceed that. So if a patient, is say, if you were dosing them at 50 mg per kilo per day, divided Q8 to 12, and you got to a point where you're exceeding 500 milligrams Q8, you would just cap it out of that. So just cap out at the adult dose. That way, make sure you don't give them too much. This is going to be the most common one that we use, and is also going to find to be less sensitive to extremes of weight than just age-based dosing. But based on kids who are extremely overweight or extremely underweight, you may find some differences in med clearance. And so it is still possible to give an inappropriate dose based on just their weight alone. So again, there's potential for overdosing or underdosing, especially in these very overweight kids, and we know this is a big problem. Increasing incidence of obese and overweight children is going up all the time, so it's important to take this into account. And there's some strategies we can use, like using things like adjusted body weight, but really kind of outside the scope of this class right now. Another thing that you can do in order to take into account kind of extremes in height or weight can be by using body surface area. Essentially, this is where you dose drugs based on certain milligrams per meter squared. And so this is nice because it takes, when you figure out BSA, you're looking at the patient's height and weight, which means it's going to be much more sensitive to some of the, or less sensitive to big extremes in weight, especially with kids that are taller or shorter. So this is probably the most precise way to dose meds, but it is not used very frequently. We use it a lot for cancer treatment when doses need to be very, very exact, but it's also more cumbersome to figure out, and so we will usually not use this for the majority of medications. Usually weight-based is good enough for most drugs. Some disadvantages, because it utilizes the height or the length of the child, it can be sometimes difficult to determine that. One, if they are kind of fighting with you and are not wanting to be take their height very well, or for some patients they may have like things like spastic muscles. They have kind of contractures that may make it very difficult to estimate an appropriate height. Also, there's many variations on BSA calculations, so make sure that you're using whatever one is appropriate for that institution. That way you can be consistent in your calculations. So looking at intravenous drug administration or just different drug routes in general for pediatrics, again, intravenous is going to be a very common one, especially in hospital world. You need to look at several things, though. You need to look at things like the volume of the drug that you're administering. Sometimes we will find that you want to use as concentrated of a drug as you can, so that way you're not giving too much volume, especially in very small kids. Imagine if you're dealing with a kid who only weighs, say, 1,200 grams, a very, very small, usually premature neonate. You can find that even a few mLs of drug is enough to change their whole volume status pretty significantly, especially if they're receiving multiple drugs at different frequencies and whatnot. Not only that, but like intravenous drug administration can be very difficult in pediatric patients due to the fact that their veins are very difficult to either find or to get an actual working IV in. So that can be very problematic as well. And then looking at therapeutic drug monitoring, as we mentioned, this is where we're using plasma samples in order to estimate drug levels. Having too many lab values being done on these kids can be problematic because you can see appreciable drops in their hemoglobin hematocrit by taking out too much blood. Not really a big problem in children and adolescents, but certainly in neonates you can see issues with this. And so this is why we try to coordinate all of our drug levels, so that way we have to draw the smallest amount of blood possible and kind of maximize our the labs that we can do on one sample. Here's an example of a way that we can administer IV medications to pediatric patients. It's really important that we make sure we're not giving too much volume. There's been cases of kids who have died when they say took a small neonate, they hung a liter bag of fluids and didn't use a pump or anything to limit the amount of fluids going in. Whole liter went in, ended up causing big pulmonary edema, patient ended up dying from that. So because of that, we utilize technology to make sure we're going to infuse just the right amount of drugs for these patients, either with using a pump like this, where you can have drug either in a bag or in a some sort of mixing chamber, and we'll administer it throughout the site, be pumped through and then into the patient. We also have certain syringe pumps as well, so I'll show you an example of that in just a minute. Basically, and here's an example of a syringe pump. A lot of these are pre-programmed in with libraries that will say, okay, well, based on the weight of the patient, here are the limits of the doses they can receive. Here's how quickly you can administer the drug. Sometimes you don't want to go too fast or too slow. And that way you're able to make sure you have as safe a medication administration as you can. Because again, they're much more sensitive than adult patients are going to be. And so this is why you need to be so precise. So in this case, you would have the drug here in the syringe, pop it in. This clamp right here is actually able to determine the thickness of the syringe. It can tell you what size it is, whether it's a 30 ml or 60 ml syringe, and that way it knows how quickly to move in this plunger here to make sure that you're going to be administering the right amount of drug at the right rates, right? So again, library management is very, very important here to make sure you stay on guardrails is what we call it. You never want to go off guardrails because you're kind of dosing things. Hopefully your math is correct and hopefully you've chosen the right parameters, but we like to leave human error out of it as much as we can. For oral administration, this can be exceedingly difficult. I don't know if anyone of you have ever given oral medicine to a kid. I never appreciated how tough it is for nurses in the hospital until I had my own child to try to give drugs to, and it's not easy. One of the things you want to be careful of is the measuring devices. I'm sure most people grew up receiving medications in either teaspoons or tablespoons. Just for reference, a teaspoon contains 5 mLs of fluid, and a tablespoon should contain 15 mLs. of fluid. The problem is there's a lot of variability in the size of spoons and things like that. So if you go to IKEA and get a Swedish spoon, it may be different than you would see from, say, somewhere you might get from, say, Walmart. So because of that, there's a lot of variability and there's lots of errors in dosing of drugs that have occurred before. And so nowadays we only recommend dosing in mLs if you're giving liquid medications, because again, most of the patients are not going to be, a lot of patients are not going to be old enough to take things like tablets. So this is why we use so many liquid formulations. Get to consider, just how, so in order to dose in mLs, basically we give out dosing syringes where, again, they're not compatible with IV syringes. That way the connections aren't the same, but you can drop the dose out of the bottle and administer the correct amount, the very exact amount, rather than kind of guesstimating how much is in that spoon. So other things to consider, the sensory appeal of the dosage forms, is the taste appropriate to where the kid's actually going to tolerate it? When I grew up, medications all tasted very terrible, but nowadays you can have it flavored to almost any flavor and find something that the kids will like and will want to take. Think about food-drug interactions, if certain drugs may be bound up by certain things. So if you're giving antibiotics that bind up with calcium, that could be problematic, and we tell a lot of kids to drink plenty of calcium because they're trying to develop bones, right? And also certain inactive ingredients. Some kids may have allergies which preclude them from getting certain dyes, certain inactive ingredients, and so you always have to take that into account as well. So when you're prescribing medications for these kids, make sure you always obtain as most current of a weight as possible. Again, oftentimes you may have to convert between things like, patients. Actually, we just had this the other day when we had a 6-week-old come in, and basically we were in a state where we're actually having to code the child and come up with very accurate drug doses of things that would ultimately either save or not save his life. And so the parents are like, okay, well, the patient, last time we weighed him, he was 4 pounds 6 ounces. Okay. Well, now we got to convert that over to kilograms because that's how we dose all of our medications. And so it's very important to make sure you get an accurate weight, and then we also convert the weight over accurately. So for instance, in that case, I was able to take the patient's weight, figure out how many, basically 16 ounces in a pound. So they would figure out specifically how many pounds he was, and then convert it over into kilograms. And that's the dose we use for the rest of that code. So, if had I screwed that up, we could have been administering the wrong doses of medication to that child for the rest of that code. And it could have been, could have meant the difference between life and death. So again, current weights are super important for dose checking. Also, check your references. Either if you have whatever drug reference you use, make sure you're checking to make sure that the dosing you're looking at is appropriate for the age of the kid. Oftentimes, you'll find that there's neonatal specific dosing and then child specific dosing and then adults. And then whenever prescribing, you always have to consider counseling as well. So if the child's old enough to understand, you want to make sure you're going to give them education as well and make it specific to their language capabilities. So especially like teenagers, they have to be more independent. Talk to them. You don't necessarily need to talk just to the parent. Be kind of very paternalistic in that case. You can be much more empowering to the child and make sure that they feel like they're in control of their disease and their care. So just briefly, I'd like to go over some drug dosing calculations just to make sure that you guys can do this and do it for an actual patient you may have to deal with out there in the real world. So let's say, for instance, in this case, we have a 15-kilogram child. It's going to require amoxicillin for acute otitis media. And basically, we're going to be giving him 90 milligrams per kilogram divided twice a day. So BID is twice a day. And so we know that our amoxicillin suspension comes as 400 milligrams per 5 mLs. And so the question is, how much should this child receive per dose? So the way we're going to do this is we're going to say, well, okay, based on the dose per day, we know that the patient should be getting 15 kilograms times 90 milligrams per kilogram per day. Basically equals 1350 milligrams per day that they're receiving. So we know, based on what we're seeing here, this is divided BID. So we need to divide this number by 2. And so we get 1350 divided by 2 equals the kids should be getting 675 milligrams per dose. Okay, that's great. But you can't just write, that on the prescription and say, hey, give this many milligrams. You want to figure out how many mLs it is. So that way the mother can draw up the right dose. The pharmacist can double check the dose, make sure everything's appropriate. So you got to convert that over as well. So basically what you can say is that it's 675 milligrams per dose. You figure out what your concentration of your antibiotic is. In this case, it's 400 milligrams per 5 mLs. And notice this is just a holdover from that teaspoon, tablespoon kind of dosing. So everything, for the most part, gets communicated in milligrams per 5 ml. So you just divide this out. And so say, okay, well, I know it's 80 milligrams per ml. So you take 675 divided by 80, and thus you have 8.4 mLs per dose the child should be receiving. So you basically write on your prescription, amoxicillin, 675 milligrams, in parentheses, 8.4 mLs per dose, twice a day for, say, 7 days or 10 days or whatever it happens to be. So pretty straightforward, but again, you want to practice a few times and make sure that you're able to do this on your own. And now, fortunately, most of you guys will never have to do this by hand outside of school because you'll have a lot of electronic medical systems that will help you with this. But again, it is imperative that you at least know how to do this, so that way if the system goes down, you have to write a paper script, you can do it. Okay, so the next problem we have here, say we have an 18 kilo patient who's going to need Zantac, which is a H2 blocker. It's going to be for GERD symptoms. And so basically the dosing you would see in your drug reference would be 4 milligrams per kilogram per day. And it's going to be divided twice a day. And so we know that the Zantac solution comes as 15 milligrams per ml. And so now the question is, how much should that patient receive per dose? Okay. So the way we can do that, and again, I'm going to actually do the math here with you. I don't have it pre-done, so I can make sure that we can kind of do it in real time as you're listening to this. But first thing we need to figure out is how much should the patient receive at a time. And I apologize for my very poor handwriting, but we're going to try to write this out. But basically, we have 18 kilograms. This is really, really embarrassing, but I say 18 kilograms times 4. Okay, so that's going to equal how much that patient should receive per day. So we're going to 18 times 4 equals 72 milligrams. Okay, so basically that's how much the patient receives per day. But now we know we need to divide that twice a day. So it's 72 divided by 2 to an equal 36 milligrams. So 36 milligrams. That's going to be per dose, right? Again, this is ridiculous handwriting, but I'm going to say, okay, that's per dose. Make that look a little more like an S. Okay, so 36 milligrams per dose, and then now we need to figure out how much volume we're going to give per dose based on the concentration. So now you take 36. You're going to divide that by 15 milligrams per ml. So basically, we're going to get 36 divided by 15. Yeah, that should equal 2.4 mLs per dose that the patient is going to receive, right? So this would be instruction. That way the mom knows how much to draw up, or the dad knows how much to draw up to make sure they're going to be dosing it appropriately. Okay, so pretty straightforward. And again, just you can make up practice problems for yourselves. You guys have access to drug references through your library, so you can look these things up and try to ask sample questions to back and forth to make sure you're comfortable doing this. So let's say in this next one, we have a 12 kilo patient who's going to be receiving a drug. It's called trimethoprim sulfamethoxazole. So it's a combination antibiotic that was sometimes used for cellulitis. And so another brand name for this one would be Bactrim, or Septra would be another name for this one. And so we can see that our dose that we're going to give is 4 milligrams TMP per kilo per dose divided BID. That TMP, this is how you'll frequently see Bactrim being dosed, stands for trimethoprim. So we dose this drug based off the trimethoprim content, and because we know that the sulfamethoxazole comes as a fixed ratio to the trimethoprim, which you can see the concentration here, this 200 milligrams of sulfamethoxazole and trimethoprim 40 per 5 mLs. Because this is a fixed ratio, we know as long as we're giving the right amount of trimethoprim, they'll still be getting the right amount of sulfamethoxazole, right? So again, this is where it's important to know specifically which component of the drug you're basing it off of, because if you did it wrong, you could get a 5-fold overdose or underdose depending on which way you went there, okay? So let's go ask the question again, how much should this child receive? Okay, so going again with our pen here, again, very poor handwriting. Let's say we're going to say, first off, how much should the patient actually receive? So say 12 kilos times 4 equals 48. So we know that 12 times 4 equals, patient should get 48 milligrams of trimethoprim. So TMP. Okay, so that should be getting that much of that drug, right? So we're going to say, okay, well, that's 4 milligrams of trimethoprim per kilo per dose twice a day. So notice in this one, we don't really need to divide this out, right? Because this is already per dose. So I know the patient's already getting 48 milligrams per dose versus getting the drug divided twice a day, essentially. Okay, so again, it's important to know whether or not you need to divide by 2 or not. In this case, you do not, because this is already in milligrams per kilo per dose. Okay, if it said mgs per kilo per day, then yes, you would need to divide that out. Otherwise, you don't need to, because it's writing per dose. And that can be really, really important, because I've had cases where a doc would write for, he meant to write for 50 micrograms of a drug, and he accidentally wrote for 50 mics per kilo per dose, and you know, can see a huge amount of dosing error that can happen there. So it's really, really careful when you're looking at your dosing units. You can see here. But anyway, based on what our suspension is, so basically we're going to focus on the just trimethoprim component. We're going to see this 40 milligrams per 5 mLs. I'm just going to divide that out and say this is going to be 40 divided by 5 is going to give us 8. And so this is going to be 8 milligrams per ml here, right? So basically at this point, all I got to do is take our 48 milligrams, divide that by 8 milligrams per ml equals 48 divided by 8 is going to equal 6 mLs. So this means the child should be receiving 6 mLs of this solution twice a day. Okay, so again, we didn't have to divide by 2, because again, this is going to be mg per kilo per dose. Okay, next question. Let's say we have a 20 kilo child who's receiving 2 teaspoons of acetaminophen 4 times a day for fever. The usual dose that we may give is, say, 15 mg per kilo per dose. We know our acetaminophen suspension comes as 160 milligrams per 5 mLs. And so the mom is coming back to ask, hey, is this kid being dosed appropriately? Am I giving the right amount of Tylenol to my child? Okay, so some of the questions you have to ask is, okay, well, based on what the kid's getting, and we see the dose he's getting is 2 teaspoons of acetaminophen 4 times a day. So 2 teaspoons, we said a teaspoon is 5 mLs, so we know the child's getting 10 mLs per dose. Okay. So we know he's getting 10 mLs per dose, and we can see that the suspension is coming as a 160 milligrams per 5 mLs. So you could divide that out and say, okay, well, the kid's getting, it's a 32 milligram per ml suspension. You could just double this, though, because we know the kid's getting 10 mLs. So you can say it's 320. Okay, so basically it's going to equal 320 milligrams of acetaminophen per that dose. This is a total of 320 milligrams. Okay. So now the question is that too much for this kid, or is it enough? And so basically the next thing you want to do is figure out what the kid's actual dose should be. So we know the usual dose is 15 mg per kilo per dose, and we know the kid weighs 20 kilos. So we can do 20 times 15, and that should equal 300 milligrams. So the kid's total dose should be 300 milligrams. Oops. And we can see here that he's actually getting 320. So again, usually within a 10% range, you're probably fine. So again, getting a little bit of an overdose, 320 versus 300, clinically is not going to make a huge difference. So again, you could say, yeah, that's enough for him. Just go ahead and stick with the 2 teaspoons as long as the mom's actually measuring out 10 mLs. Then that should be totally appropriate for that child. Okay, so the next thing we can come across is our fluid boluses and fluid maintenance. So we only mention this because, again, it's good to have some cognizance of it now, so that way you can use this information from here on out the rest of your courses, because you can, especially when you go on rotation, you can look like a superstar when you already know how much a kid should get fluid bolus with and what their maintenance fluids rate should be. So in general, a fluid bolus for a child should be 20 mLs per kilogram. Okay, this is flat for almost every kid. You really can't go wrong with this number unless they have already a significant amount of fluid buildup. If they have kidney dysfunction, you may want to bump it down to, say, 10 mLs per kilo. Some kids who are very dehydrated may need more than this, but this is a good single fluid bolus you want to give. And usually we cap it out at a liter. Anything more than a liter, we usually would just save and maybe give another bolus if we need to once you've kind of reassessed the patient. Now, as far as fluid maintenance calculations are going to go, we like to follow what we call the 4-2-1 rule. And essentially that means that for the first 10 kilograms of the patient's weight, you can dose this as 4 mLs per kilo per hour. Okay. For the second 10 kilograms, you can mean that you will use 2 mLs per kilo per hour for the second 10 kilos. And then for every subsequent kilogram after that, you're going to use 1 ml per kilo per hour. So this means that in total, this would mean that for the first 10 kilograms, the patient should get a total of 40 mLs per hour. For the next one, for the next 10 kilos, you'll get a total of 20 mLs max per hour. And then after this, it would be another ml for per kilo per hour for every subsequent kilogram. So basically off this, we can basically figure out like what our maintenance and fluid bolus rate should be for our patients pretty easily. So for instance, if we had an 8 kilogram infant, let's say here we wanted to do 8 for his fluid bolus, we'd do 8 times 20. And we see that his fluid bolus would be 160 mLs. That should be a 6. But you can hear me, so that's okay. For his bolus, and then for maintenance, basically would say, well, okay, he's under 10 kilos, so I'll just do 8 times 4. So 8 times 4 is going to be 32. And so his maintenance rate would be 32 mLs per hour. Okay, so moving on, next we have the 1,200 gram neonate. So keep in mind this is in grams, which means that the patient actually weighs 1.2 kilograms. So if I wanted to figure out what his fluid bolus would be, I would do 1.2 times 20. And so for him, this little guy, he would end up being 24 mLs is the fluid bolus. Usually give this over half an hour to an hour or so. And then for his maintenance rate, you'd just be 1.2 times 4. So you do 1.2 times 4. And his fluid maintenance rate would be 4.8 mLs per hour. Again, it's important to keep that per hour in there, not just 4.8 mLs total, because then otherwise he wouldn't be getting a maintenance rate for very long. Okay, so that makes pretty good sense. Then next, let's look at the 45 kilogram adolescent. So again, here's where we can utilize, or at least for our fluid bolus, we'll say 45 times 20 equals 900. So this patient would get almost a liter of fluids for their fluid bolus. Okay, and then for their maintenance rate, basically we'd say, okay, for the first 10 kilograms, they're going to get a total of 40 mLs per hour, right? Because it's 4 mLs per kilo per hour for the first 10. So our maintenance rate for this person would be 40 plus, and then for the second 10 kilograms, you're going to get a maximum amount of 20, right? So plus 20 plus, and then now we just use whatever's left over in mLs per hour. So for this kid, it would have another 25 kilograms left over, so we plus 25. So the total fluid amount this patient would be getting per hour would be 40 plus 20 plus 25, which would basically equal 85 mLs per hour. Okay, and then for our last example, looking at a 100 kilogram teenager, let's say we can go ahead and do 20 times 100. And that would give us a total of 2,000 mLs for fluid bolus. And I said usually we go ahead and cap it out at 1 liter, and then we can go back and reassess, and if we need to give more, we can. Now, there's going to be some exceptions where you would want to go above this. So imagine if a patient came in either very, very, very dehydrated, or they had massive trauma and they were losing a lot of blood, or if they were septic and they had hypotension. Like, those would all be reasons why you want to give more. But in this case, you can just start at a liter, because again, with fluids, you can always give more. You can't take it back once you put it in. Okay. Now for his maintenance rate, again, we're going to do the same thing we did for the first kid. So we're going to, or this 45 kilo kid, but basically for the first 10 kilograms, we're going to do that 40 mLs per hour plus 20 for the second 10 kilograms, and now we still have an extra additional 80 kilograms we got to account for. So 80 here. So that would equal to a total of 140 mLs per hour. Now, please, on my reviews, please grade me based on the content of my material and not on my handwriting. Again, I am usually left-handed. This is all right-handed, so it's not just modern art. It's just my poor handwriting. So anyway, hopefully this makes sense. If not, please try some practice problems. Try it out with some friends. You can kind of go back and forth with one another, make kind of scenarios where you can come up with different situations and come up with these answers. And of course, you always feel free to send me messages or approach me in class if you have any questions I can answer for you. One other question that usually comes up, it's kind of interesting one, is like, what's the max dose of something that I can give for a patient? What's the absolute max I can give? And so this comes up a lot for lidocaine. And so especially when we're doing like suturing and whatnot. So in the ER, we have kids that come in with lacerations that need repaired. And so what they actually will do is the medics will be like, well, how much can I give of say like a lidocaine 1% solution, lidocaine being a local anesthetic. And so one of the things you want to figure out is, well, I have a 1% solution, like what the heck does that actually mean? Not a lot of people actually understand when they see a percent solution, what that actually means. All a percent solution means, and again, I'm going back to my poor handwriting, it just means the number of grams you have per 100 mLs, or deciliter as it would be, right? So this isn't useful because I don't really care if there's 1 gram per 100 mLs of lidocaine in that 1% solution. Like I want to know how many milligrams per ml I have, because that's a more usable concentration when I'm trying to figure out how much I want to give to a patient. So a handy trick you'll find when dealing with percent solutions is that if, say, you start out with a 1% solution, all you have to do to convert this over to milligrams per ml is just move the decimal spot over one place, right? So basically all that means is that for a 1% solution, the concentration is actually 10 milligrams per ml. Right? For instance, if I had a 2% solution of lidocaine, which sometimes that will come as, I just move the decimal place over one spot to the right, and that means 20 milligrams per ml. And you can do that with anything. If it's a 0.4% solution, you can just move it over one decimal place over to one spot, and it would be 4 milligrams per ml. You can do that with anything. So the important thing is say, for instance, the paramedic came up to you and said, hey, PA, Mr., Mrs., I would like you to tell me what's the maximum amount of lidocaine I can give this patient. And so you would look up in your reference and you'd see that, hey, I can give a total of 5 milligrams per kilogram at one time. Okay, so that's good to know. So you can say, well, for a 24 kilo patient, you do 24 times 5. Patient can receive a max of 120 milligrams of lidocaine, right? And so the next question is, well, how much volume can they give? Because the paramedic is, it's fine you tell them how many milligrams it is. They want to know how much volume they can inject into that suture site in order to get it ready for putting actual sutures in. And so based on what we know with the 1% solution, we could say, well, I know it's 10 milligrams per ml based on the calculation that I already did, 10 milligrams per ml. And so you just do 120 divided by 10, and basically you get the patient can receive a total of 12 mLs. So that's what this is the number they really want to know, because again, this is what they are actually going to be using on the patient. They're not going to measure it by milligrams as they inject it. They're going to measure it by mLs. And so again, that's the max they'd be able to receive in that case. So again, sorry for the bad handwriting, but you at least get the concepts there. So anyway, that finishes up our geriatrics and peds section. Again, it was a little fast, but of course I didn't really have any student interaction to go along with it. But certainly if you have any questions or any clarifications, we can cover either next week, or you can send me a message and I'm more than happy to clarify in the meantime. But thanks again for bearing with me, and I'll see you guys next Wednesday.